Okay, so this is an overview of the administration of sedation. And the first thing you do is you have to do the preparation of the room. So at this point, Professor Hung is reviewing the anesthesia machine, checking the equipment, and going through to make sure that everything is basically properly in place. There's emergency airway equipment that must be available. That's an oral airway to pick the tongue up from the back of the throat. This right here is called a nasal airway. That goes through the nostril to the back of the throat, again, so that air can go past the tongue into the trachea. This is called a laryngoscope. Can you just pause for just one moment? And the laryngoscope is what you use in an emergency if you cannot move air into the patient. It's not surprising that we're starting our setup with airway equipment because the single most important aspect of anesthesia ever is continued movement of air into the lungs. That's the most important thing we do, is we move air and oxygen into the lungs. So we're starting with simple things. An oral airway, which will just pick the tongue up in case the tongue falls to the back of the throat and blocks the movement of air. If that doesn't work, there's something that goes through the nose. Again, it's to go past the tongue so that air can get past the tongue into the windpipe. But if that should fail for some reason, then we may actually have to look inside the throat. And if you're going to look inside the throat, this is the instrument we use, the laryngoscope. And at this point, Professor Hung is evaluating that the laryngoscope, the blade and everything is working, but most importantly, that the light works. Thank you. Okay. So he verifies that the light works. Now the next step here is the endotracheal tube. Can you pause, please? The endotracheal tube is what you use if you need to get air directly into the windpipe. Rather than trying to go through the mouth, that tube is placed through the mouth right into the trachea, right into the windpipe. To do that, you need a laryngoscope, and you use the laryngoscope to look inside the mouth, and then you can see the vocal cords. And that tube is passed between the vocal cords. So that is something that an anesthesiologist always has ready as essentially your fail-safe. If all else fails, you can put that between the vocal cords and give air through it. Thank you. Okay, if you can, this is called a laryngeal mask airway. If you can pause this. This is an invention just within the last about 15 years. And what this does is it doesn't go into the trachea. Instead, if I may use my laser pointer here, this part that you see right here, this is a soft rubber portion. Let's see, this laser pointer, here we go. This right here is a soft rubber portion.
To the left.
Correct. And that goes in the back of the throat. And that goes in the back of the throat, but it wraps right around the larynx where the vocal cords are, so that everything is pushed out of the way. So you don't actually have to go into the windpipe itself. You just put this, it's called a mask airway, but it's a little mask for the inside of your throat, sitting right on top, again, so there's an unimpeded flow of air and oxygen to the lungs. That is our most critical responsibility in anesthesia, is unimpeded flow of air and oxygen to the lungs. So we have multiple systems to see that that happens. You may continue, please. So this is placed, and he's just verifying that he has the unit here and that it appears ready to go. So I mentioned everything is organized. That may sound silly, but it's actually really important because when there are problems, you have to respond in anesthesia in a matter of seconds. You have to know where things are. It has to be set up. If you have to walk even a few feet and the patient's not getting oxygen, it's a few feet too far. So everything is placed where you know exactly where it is. And you can grab it literally in a heartbeat, your own, to have that instantly available for the patient. Continue.
The slide is entitled Verify Primary Oxygen Delivery.
Yes, thank you. So oxygen delivery is key. And we have multiple sources in the operating room of oxygen. This right here is oxygen for a sedation case that will come through nasal prongs. And what you do is you have to see that, is it hooked up? Does the plumbing work? The anesthesiologist is responsible to be sure that this works. So, if you continue, please. So Dr. Hung here now opens it up and verifies that, yes, here's the tubing. Is oxygen coming out of this? That goes in the nose. And what he will do then is he will now stop. Oh, stop, please.
Sorry.
So he's looked at the tubing. There were two little, what we call a cannula there, one for each nostril. Only one contains oxygen. The other tubing is used to measure the carbon dioxide. So one tubing gives you oxygen, but the other measures carbon dioxide, because carbon dioxide is in every time you exhale, there's carbon dioxide in your exhaled breath. And so we measure that in anesthesia with something called a capnometer. So he is now taking that tubing and hooking it to his machine to verify that he can measure moment by moment the carbon dioxide in the breath as the patient exhales it. Please continue. So he attaches that to the machine, and now there's an easy way to test this. He uses his own breath. He exhales, and he sees the carbon dioxide go up and down on the monitor. So using his own breath, he verifies that that works. Please pause. This is the anesthesia breathing circuit. We've talked about ways of opening the trachea and the lungs to air, but something's got to move the air. If the patient is being sedated, hopefully the patient's own diaphragm and chest will expand and contract and move air in and out of the lungs. But if the patient won't move air, we have to do it. We have to have a way of forcing air into the lungs if the patient isn't breathing. And that is the anesthesia breathing circuit. There's a mask which you can see there, and if you could just wait for one more moment, Mr. Walgren. There's a mask you can see there that goes on the patient's face, and we learn how to hold the mask so there's a tight seal on the patient's face. And then there is a bag that you squeeze, and that pushes the air into the lungs. So that's coming up here. Continue, please. So this is the anesthesia breathing circuit. He has put his finger there to block it. Why did he do that? Because he wants to see that he can maintain pressure. So he now squeezes it, and he can feel the air coming through the mask with his finger to verify that. Stop. So he verifies that you can squeeze the bag. An anesthesiologist always checks before every operation that you can squeeze a bag, and with the tubing that goes to your mask, you can force air into a patient who is not breathing. We now turn to suction apparatus. Suction apparatus is essential because one of the most feared complications of anesthesia is if the contents of your stomach get into your lungs. Your stomach has acid. The acid is intended to break down your food. If that acid gets into your lungs, it starts to break down the lungs as though that was food. Acid is not as bad, though, as bile. When you throw up that green stuff, that's bile. Bile immediately starts dissolving the lungs immediately. So bile in the lungs is almost 100% fatal. So this is a very feared complication in anesthesia, and every anesthesiologist is very attuned. If you ever have surgery, they'll say, don't have anything to eat or drink the night before surgery. Why do they say that? It's because they don't want anything in your stomach. Because they don't want you to have anything in your stomach that could possibly go into your lungs. The suction is absolutely necessary because if something comes up in your throat, the anesthesiologist has only the time until the next breath to put a suction catheter in the back of your throat and remove the vomit that just appeared there. So if a patient is sleeping and there's a little and something comes into the back of the throat, it'll sit there until they take a next breath. That can't happen. You have to get the head turned. You have to get the suction catheter into the throat and remove all of that before even a drop goes into the lungs, because it is very, very toxic. A drop, certainly a cc of bile, could be fatal. So you check the suction apparatus. You have to know that it works. So here he takes the suction apparatus. This is absolutely critically important for safe sedation. You'll see him now put his hand over it, continue, and he checks that he can feel the suction coming through that. And then he looks down at the control device here and verifies that it can actually create suction. Because you are responsible, stop. The anesthesiologist can't say, oh, the maintenance person made a mistake. The anesthesiologist is responsible that everything works. There's no, oh, somebody didn't check a form or something. You're responsible. You check that everything works before the case starts. So now I go to the backup oxygen tank. This is necessary for a variety of reasons, including the possibility that the main oxygen supply might fail. So in this case now, Professor Hung checks the backup oxygen tank and verifies that the tubing is attached. And that is also attached to a resuscitation bag. Now please stop. This is a different bag than the first thing I showed you, which was the anesthesia circuit. Why? It's kind of a belt and suspenders approach. Belt and suspenders. You wear suspenders just in case your belt breaks. In this case, you have the anesthesia circuit. But every operating room, every procedure room has a resuscitation bag as well. So that if for some reason the anesthesia circuit would fail, you have this as a backup. The theme through all of this is uninterrupted supply of air and oxygen to the patient. That's what can never be compromised. And so you can see multiple approaches to the airway, multiple approaches to having oxygen available, and two different ways, the anesthesia circuit and the backup bag available in the operating room, so that you can force air into a patient who stops breathing. Please continue. And there he's verifying that he can force oxygen into the lungs with the resuscitation bag. Stop. If infusions of drugs are used, they are almost always done with a pump. A pump is a mechanical device that allows you to set the rate very precisely. The pump has to be set up very carefully so that it knows everything it needs to know about the drug, like what is the drug, how concentrated is the drug for many kinds of pumps. Some pumps will actually adjust based on the patient's weight. And so you have to enter the patient weight. This takes some time. This takes about 5-10 minutes in the morning or before the next case to set this up. So the anesthesiologist does this long before the patient is brought into the room, has the infusion pump set up and ready to go. Continue, please. So here is the propofol that he's going to use. And this, I believe, is similar, if not identical, to the vial that you've seen. It's identical. It's a 100 ml glass vial. He removes the foil as shown. Now he's going to draw this into a syringe. Can you stop for a moment?